Welcome to EAU 2026 in London. My name is Neha Sihra. I'm an associate editorial member of the EuroLUTS educational platform, and today I have with me Professor Thomas Kessler, who is the Vice Chair of the Neuro-urology Guidelines. And we will be discussing some of the exciting updates of the 2026 Neuro-urology Guidelines that were released just yesterday. So, welcome to London.
Thank you, Neha.
So tell us more. What are you excited about? What are the main changes that have happened in the guidelines this year?
It means there's no real exciting update on that part. It is not a single one. It is all. This is the great way, because when you're thinking about the EAU guidelines, they are updated regularly. When we compare AUA guidelines on neuro-urology, they were released 2021 and haven't been updated yet. They're completely outdated. And this is the exciting thing, what we really have at the EAU. But one point I really like to highlight is that we have included a section on patient's perspective. We have two representatives from the patient perspective actually as patient representative in our guideline panel. And this is a big step forward.
Absolutely. So important, isn't it? We always sort of talk about the importance of shared decision making, and that's exactly where the patient's perspective comes into it. We may often overlook what patients' values and preferences are when we're sort of formulating management plans. So it's really, really important to have them involved. I mean, one of the sort of key areas that they could potentially help influence is the whole sort of focus on intermittent catheterization and the potential changes that we might be seeing in the next couple of years. So one example being sort of the type of catheter, single use or reusable. So again, getting the patient's perspective on that would be really, really important. And what are your thoughts on that? Is that something that's been mentioned in the guidelines update this year, or is it too premature?
Yeah, at the moment we haven't included that. We had this morning this game changer session actually where we really entered Bertil Bloch's trial compare, where it came out that single use versus reusable catheter is almost the same. And having this perspective included in the future, this is just a very, very big step forward.
Yeah, absolutely. And a sort of another really important area is urine infections, so UTIs. We know that there's been a recent change in the terminology of complicated versus uncomplicated UTIs, and of course, neurogenic UTIs were always deemed as complicated. So the classification has changed to localized versus systemic. Is that something that's been incorporated into the guidelines updates, and how would that sort of influence the way we manage our patients?
In neuro-urology, we have the big problem, what is a UTI? It means, answering your question, there's no change on that. But I can tell you what we are currently doing is to bring up a consensus work. This will hopefully integrate it the next time, in the next update. What is a real UTI with a patient with an underlying neurological disease? And the big problem here is this is completely out of the box when you think on the non-neurological patients, because you have not the sensation, you have different problems, and spasticity, things like this is completely in a different range.
Yeah, definitely. I mean, another area that I'm really excited to sort of read about and see what the future holds is the role of neuromodulation for managing our neurogenic population. So is there any big changes that have happened on that with the current guidelines updates?
In the current guidelines, what we have in what it is published, it means there is, for sacral neuromodulation, for instance, is only one randomized controlled trial that it is published yet, and for other types of neuromodulation, there are also some RCTs, but the question is also how they are designed, what is the heterogeneity of the included patient, and so on. And what is a clear need in the future to have more neuromodulation trials coming up.
Yeah, absolutely. And again, sort of, it's really important for this patient population specifically, who often have issues with overactive bladders, voiding dysfunction, and bowel dysfunction as well. So it could be revolutionary for some of them. And you say the sort of importance of having the relevant evidence for the different types of neuromodulation, but the patient perspective would also be really important for that aspect of the guidelines.
Especially, and as you just mentioned, we have this different type, like storage problem, but also voiding problem, bowel problem, and then you have to focus what is the dominant problem that you would really like to improve. Ideally, you improve all, but the reality is that in some types it's working better and in the other less.
Exactly. So yeah, really exciting to see what, we can see in the next few years in terms of sacral, tibial, pudendal neuromodulation for this patient group. You mentioned earlier about the AUA guidelines. Apart from the fact that it hasn't been updated for a few years, are there any other sort of key differences between the EAU guidelines for this patient population and the AUA guidelines?
In principle, they're quite similar, but with the big but, our American colleagues, they are 5 years behind us because they have never updated their guidelines. Therefore, use the EAU guidelines, please.
Absolutely. So no, very exciting. So potentially lots to see over the next few years. Anything else that you wanted to sort of highlight today about some of the key changes within the guidelines?
It means to have now also including patient's perspective, shared decision making, some statements about botulinum toxin that wasn't included yet. There are other points where you clearly, I have to advise you, look into that into a detail. You find what it is out as a publication perspective now.
Absolutely. And you mentioned the sort of change to one of the statements about botulinum toxin. Could you tell us a little bit more about that?
Yeah, it means it is all about efficacy and safety. And the question is where you put that into the guidelines, and what we had, there was no clear recommendation on that. But it is very clear after antimuscarinics failed, then go on to botulinum toxin treatment.
Yeah, absolutely. Amazing. Well, thank you very much, and I look forward to reading them in detail.
Thank you so much, Neha.
Thank you.